Welcome to the podcast of the European Society of Anesthesiology and Intensive Care. This Industry Corner episode is currently supported by Medtronic. I'm your host, Thomas Fuchs-Buder, Professor of Anesthesia and Critical Care at the University of Lorraine in Nancy, France. Today we will be discussing the topic Sedation Standards for Safer Care. And there we have invited Massimo Lamperti, Professor of Anesthesiology at Cleveland Clinic Lerner College of Medicine and Chair of Anesthesiology Institute at Cleveland Clinic, Abu Dhabi, in United Arab Emirates. Welcome to today's podcast, Massimo. It's up to you.
So thank you for the invitation. And today I will present an overview on the guidelines that have been published in 2018 and we're now going to update regarding safe sedation for adult patients. So first of all, we have to put a definition of what is considered procedural sedation analgesia, or PSA. So this is the definition that was done involving the use of hypnotic and even analgesic medication that are allowing us to do in general procedure for both diagnostic and therapeutic methods in adults. And these mainly procedures are sometimes involving even some potential adverse effects on the patients. So this is in contradiction with what was considered before as conscious sedation. That was mainly the same term that is used for PSA, but the contradiction was because a sedation cannot be conscious, as when we induce unconsciousness in some level of sedation, we lose the conscious part. So this is a matter of debate for years with many board members from different societies who are debating or should be able to deliver procedural sedation or how to deliver procedural sedation. There are many authorities like the Joint Commission International who are mainly mandating the anesthesiology department for each hospital to be the department who has the ownership to keep the safety and to start even detailing what are the privileges that each proceduralist providing sedation should have when we deliver this sedation to any kind of patient. So the first topic that we should understand is which level of sedation we want to keep. According to different standards like the RASS scale, we should never give a level of sedation that is making the patient completely asleep and not responding to even a strong physical stimulation. This is considered more a level of general anesthesia, and sometimes it's very difficult for during a procedural sedation to keep in mind that we should not overpass this limit. Otherwise, we can encounter some adverse events like the main one that is respiratory depression. So for years we were debating on which level we should provide to patients having procedural sedation. But now the definition is more clear, and even how we should evaluate the patient before providing sedation. So anyone who's providing sedation should have a general assessment of the patient before, according to the different coexisting disease, for example, hypertension or cardiac dysfunction. If the patient has any kind of respiratory disease like obstructive sleep apnea or respiratory distress, or even had a recent upper airway obstruction or disease. On top of it, there are even some habits of the patient, like the use of some medication or even narcotic that can even put the patient to a higher risk of having complication, because usually when you have this kind of patient, there is a tendency to overload the patient to achieve a adequate level of sedation. There are even some characteristics of the patient, like morbid obesity, that are more prone to have a possible respiratory complication to the patient. So that's why it's not just the patient itself, but it's a combination of the amount of drugs that you want to give to achieve a certain level of sedation, and even the characteristic of the patient that are putting together a possible risk to develop a complication during sedation. According to the guidelines, there is even one factor that is becoming very, very prominent now. And the fact is that now we are delivering sedation mostly to elderly patients requiring simple procedures like a cataract surgery or even one endoscopy. And the age of our population of patients is increasing year by year. That's why the elderly population is now becoming the major target of the procedural sedation, with the different risk to put the patient at higher risk of complication during the procedure itself. So once we have established which kind of patient and according to the disease, which kind of complication we can have, we understood even during the guideline that it's important that to keep safety during the procedure, we should have a certain level of competence that the provider should keep. It's not just having a provider who is ACLS certified that is guaranteeing enough safety for this patient, but it's a matter of a combination of provider who's delivering the procedural sedation. She should not ever be the same provider who's even delivering the procedure itself. It should be a separate provider providing the procedural sedation. And this second provider is even the one responsible to have a safe environment. When we are talking about safe environment, we are not just talking about the availability of rescuing the airway in case of obstruction, but even in the worst scenario to rescue the patient in case of cardiac arrest. So every setting able to provide procedural sedation should be equipped enough to rescue the patient for life-threatening events. So how to do that? So it's important even to understand that not all the settings are adequate to provide procedural sedation. If the patient has to be transferred outside the facility, there are, for example, there is the need to transfer the patient with a stretcher. So that's why for sometimes in some clinic-based settings, this has to be taken in account. And it's crucial again that the provider who's giving a procedural sedation needs to be able to resuscitate the patient, and there should not be only equipment like a bag mask and or even more advanced life support devices like advanced airways, but there should be even emergency drugs available in case we have to reverse the sedation or the analgesia and to provide advanced life support to this patient. So the other key of the procedural sedation training is even considering the fact that the personnel providing sedation should be adequate trained and even to keep this competence throughout the years. So there was not a real definition on how many procedures a sedationalist should require to keep this competence. But at least there is the need to, inside each anesthesia department, to have a kind of registry on how many complications are happening if the sedation is provided both by an anesthesiologist or non-anesthesiologist, to understand what is the risk that the patient can take if there is a need to provide procedural sedation. One other topic that has been defined was regarding the monitoring. Monitoring is essential to keep a certain level of safety to our patient. So despite the fact that it's quite obvious that we should provide monitoring of the oxygenation of our patient, there were not many randomized controlled trials comparing sedation that was provided with or without pulse oximetry. But it's quite evident, is now becoming more common sense that despite the lack of level A studies, so randomized controlled trials, the need of pulse oximetry is essential. Another part is how to monitor the patient. We should always keep a visual examination of the patient because most of the times this cannot be done, especially when it's done in the so-called not operating room setting, NORA. And when this is not possible, when the visual inspection of the patient is not possible, we should have a substitute for our visual inspection. For example, pulse oximetry, when we can see if the patient has an inadequate oxygenation, or even more, the use of capnography. Capnography has been considered now a must-have, so it's a gold standard to monitor not only the ventilation of the patient, but even if the patient can start having a difficulty in his respiratory pattern up to the level he's becoming apneic, and so in this case we have to start adjusting the level of sedation and rescuing the patient, avoiding the patient to become hypoxic. So capnography is clearly the must-have that we should consider in any kind of sedation that we provide to patients, even because we never know which are the side effects that we can have. An elderly patient, for example, can respond in a different way to a minimal dose of narcotic, and in this case can suffer from first a reduction in the ventilation up to a level of hypoxia that can have even life-threatening consequences. So it's essential that we monitor the ventilation of the patient in a proper way, and capnography is the way. Another important part is to monitor the cardiac consequences, both with an EKG and with a non-invasive blood pressure. In extreme situation, we can have even the need, even for a complex patient undergoing a minor procedure under procedural sedation, we should have the need even to monitor more invasively the blood pressure to see any drop of the blood pressure, especially if the cardiac function of the patient is very poor. For example, if you have a patient with 10%, 20% ejection fraction, the need for a non-invasive monitoring of the blood pressure continuously and even sometimes of the cardiac output can let us understand for how much we should give to the patient to minimize the side effects on the hemodynamic point of view given by the procedural sedation. So there is still an area of uncertainty regarding the use of some process EEG monitors that could be used especially when we use some kind of sedation like propofol, but there is not a clear recommendation because the studies on these new monitors are still not convincing on their level of evidence. So, as I mentioned before, is the duty of each anesthesia department to keep track of the possible complication that we can have during the management of procedural sedation, and to act on these mild or even life-threatening events whenever they come. So it should be the duty of each department to have a safety counselor who is checking which kind of complication when they happen, and some of the recommendations from the Joint Commission are to keep track of this complication, and in case they will happen, to be discussed in mortality and morbidity meeting during the not only anesthesia but even in other department meetings. Because as we know now, procedural sedation around the world is not managed only by anesthesiologists, but mostly by non-anesthesiologists delivering this kind of procedure. Regarding the complication, again, the main one that is represented during procedural sedation is still the respiratory depression up to apnea and even severe hypoxia that can happen. So the second one in terms of incidence is related to airway obstruction that, again, is not caused only by certain drugs, for example, barbiturates or propofol, but can even be caused by other drugs that can create, for example, laryngospasm or laryngeal edema. And in this case, it's important that we recognize as soon as this complication will happen, how to counteract, reducing, first of all, the level of sedation and keeping the patient with an airway patent. To the extreme that when we are not able to keep the airway patent, to use or to be able to use more advanced airways, and first of all, to call for help. So it's still the responsibility of the anesthesia department that there should be always available enough support regarding the use of procedural sedation. Other possible complications, as I mentioned before, are more related to the cardiac complication like hypotension, hypertension, or sometimes in more extreme cases, arrhythmias up to cardiac arrest. So there are still some additional parts regarding procedural sedation, like the use of supplemental oxygen. Not all the patients, as we know, for example, OSA patients probably will not really benefit of supplemental oxygen. Supplemental oxygen is clearly increasing the oxygen reserve of the patient and can prevent hypoxia whenever we create a airway obstruction or a respiratory depression, but still are not preventing the possible complication. And in these cases, when we have a patient with an anticipated hypoxic period, we should give supplemental oxygen to avoid as much as possible the occurrence of hypoxia. Hypoxia, unluckily, is very common in most of the patients undergoing procedural sedation. When we consider hypoxia, we consider a level of SpO2 that is below 93%. And there are many studies showing that there are cumulative times where the patient can have this level of hypoxia during procedural sedation. So once the patient has completed the sedation and during the after the procedure, we should be even able to understand if the patient can be discharged. So there is not a clear time limit. There was a suggestion by the task force from ESAIC to keep the patient under observation for at least 30 minutes when the patient has stopped the sedation, to allow the patient to recover all the vital functions and to mainly follow the same criteria that are used in the ERAS, so to be able to drink it, and the same DREAM model that has been used for the ERAS protocol. But most of the times we should be able to understand if the patient can be discharged home, and we should not allow the patient to, for example, to drive his or her car, in order to avoid the patient could have a possible drop of sedative afterwards. And usually there are different criteria, but it's safer not to allow the patient to go home by he or herself without a proper escort. And after the discharge, another criteria is to understand if the patient could have potential complication, and it suggested that the patient should have a referral number where to call in case there is an emergency, or to go to the first emergency department in case there will be complication, even simple one like nausea and vomiting. So again, there are some complexities around the world of procedural sedation. There are even some gaps that we found when we wrote the first version of these guidelines regarding, for example, how to create a proper training for non-anesthesiologists. There are different ways to evaluate the so-called sedationalist, in order to manage properly the patient in a safe way. There are some tools like Process EG that seems to be probably a support, but sometimes the number that they provide are not able to guide enough the non-anesthesiology clinician to provide sedation. And most of all, we have even to understand that there are certain levels of sedation that are not anymore procedural sedation, but are now considered general anesthesia. So for certain reason, there is a match between the patient task not to feel any pain and to be deeply sedated, and the real level of procedural sedation, where we should never reach this level of very deep sedation that can be paired with possible complication like respiratory depression, hypoventilation, and in the worst scenario, severe hypoxia. So that's why there is a mesh that has to be filled, and still we are open to many of the queries that probably will be answered in the new version of these guidelines. They will be focused again not only to what we already assume that is considered like a foundation, like the need of proper monitoring, like pulse oximetry, capnography, hemodynamic monitoring, and inadequate management of the patient. But there are some new topics, like new drugs that are coming, for example, remimazolam or dexmedetomidine, they can still have a space, but we're still requiring more studies to understand how safe is to give those medication to the patient. And there are even other drugs like that are coming up, and probably they were not considered in the past, like ketamine. Or we can even consider how we deliver safely drugs like propofol by TCI. So these are all the questions that are coming up that we hope we are going to answer, and to provide a clear message to those who are going to provide procedural sedation in the future. So in summary, procedural sedation can be considered a safe procedure to be done. But to provide safety, we need to have a safe environment, a safe provider, and a safe way to monitor the patient, including the possible complication, to avoid that in case we will have complication, this complication will happen again. So I concluded my mainly overview on this guideline, and if you want to add something, Thomas, you can, because you were part of this big task force. So to summarize what we have done so far.
First of all, thank you, Massimo, for this excellent overview. And I realized that it is time to update the guidelines, because since the last guidelines, there are several new evaluations and new developments, not only drugs, but also in the monitoring field. But which seems for me much more important is that we need to better define what is deep sedation, what is not deep sedation, what can be done by other specialties, and what should remain in anesthesia hands. Because the limits, the border between general anesthesia and deep sedation is not a clear border. It is a continuous border to some extent. And I see in my department that more and more procedures that a couple of years ago were practiced by surgeons are now done by endoscopists, by cardiologists, by invasive procedures, not only TAVI procedures, but also the whole story of endovascular. And we feel more and more complicated discussion what can be done by non-anesthesiologists and what should still remain in the hands of anesthesiologists in terms of peri-sedational approach of this procedure. So I'm happy to update the guidelines soon. There is really need for this update. That's what I feel. And once again, thank you for your excellent overview of this topic. I don't know whether you have any comments on this.
So I share your same concern about the need mainly from both proceduralists and even patients to have a very deep level of sedation that is now considered is very debating because we should consider the patient as a patient as not as a client. So because we are mainly the last safety guardian for the patient. And we know very well when we cross this border, the limit is very narrow and you go from safety to unsafety. So that's why we have to be very cautious, especially when we will define what is considered deep sedation and when deep sedation should not be achieved anyway. Because some procedures, for example, TAVR, are sometimes requiring minimal sedation, is more analgesia that can be provided, we know very well, with a good regional block, more than providing a sedation that can impair the neurological function of a patient who is already elderly and who's not already with a good function. We know that drugs, so specialty drugs, are not good especially for elderly patients, and we should minimize as much as possible. So one very good topic to examine, for example, is going to be how to deliver sedation. We are in the world of fast food and fast medicine. We should be more precise, even precision medicine, in this case, giving to the patient the right dose according to the response the patient has. So is a little bit conflictual because we have to move fast, but we have to be precise. And this is our job, mainly, to make the patient safe. So to balance the two needs that the patient and the procedures will have.
I completely agree with you, Massimo. At the end of the day, we are patients advocates, so we have to defend the patient safety. I agree with you. I also agree with you that the risk is not only more invasive procedures, the other risk is also the more elder patients. The ask for sedation patients 80 plus or even 90 plus is constantly increasing, and these patients probably need, even for simple procedure, a correct monitoring and a correct peri-sedational approach. Completely agree with you. And these topics should be addressed also in the upcoming guidelines. Okay. We have to come at the end of this podcast, and I say thank you to everyone for listening to this episode. Indeed, the ESAIC releases monthly postcards on the ESAIC website and various streaming platforms, and we hope you will join us for the next one also. So thank you for everyone.